Hi there, I'm Dr. Stephen Krywulak, and I'm here today to talk to you a little bit about rotator cuff tears. Rotator cuff tears are a common problem that we see in orthopedics. It affects a large proportion of our population. It's a frequent reason for visits to our office. Today we're going to talk about rotator cuff issues, why they occur. We're going to talk a little bit about the anatomy of the rotator cuff and explain what it is, and then we'll talk about the problems we see and our approach to treatment, whether it be surgical and non-surgical. This is a model that we have of the rotator cuff. It's essentially the same as my shoulder as you would look at it here. If we took my big deltoid muscle off here and stripped it off, this is what you would get underneath. And it's a collection of muscles that sit on the scapular shoulder blade, front and back, and all of these tendons conglomerate and they fuse as one sheath. It's not individual tendons like you would see on your hands separated. They fuse to one blanket that covers the shoulder and provides the roof of the shoulder joint essentially. You can't tell where one tendon starts and stops. So there's 4 tendons intimately involved in this, and any one of those can tear. They're lifting your whole arm, and it's a lot like putting a shovel into snow or mud and lifting at the tip. There would be tremendous force there. So the rotator cuff tendons tend to fail right where they attach on the bone, not mid-tendon. So when we go to repair them, we're always attaching tendons to bone. In terms of rotator cuff tears, they're not all the same. People can start to tear their rotator cuffs early in their 30s and 40s. We often use the analogy of a pair of jeans. When you get a brand new pair of jeans, they're perfect, but after you wear them and wash them 10 or 15 times, you'll start to see threads and weaknesses showing in the high stress areas, for example, the knees where you bend down, and eventually one day you'll bend over and flex your knee, and it will rip at the knee. So the same thing happens with the rotator cuff. As the disease progresses and the tendon fails, you'll have small tears that will progress through those rotator cuff tendons around an arc of them, and often multiple tendons can be involved. As the tendons tear, they tend to retract back from the bone where they normally attach, and they can become a very large and retracted multi-tendon tears that are more difficult to fix. Most patients will equate a tear with pain, but many tears are asymptomatic and not all tears hurt. Most patients who have a tear of significance will not only have pain but weakness because the tendon isn't attached to your shoulder and it's very hard to initiate movement and lift your shoulder up. When you come to see us with shoulder pain, we will usually examine you and we will look at x-rays, which are also important for the shoulder and the rotator cuff. We may consider more advanced imaging like an MRI or an ultrasound to view the tendon. If we determine that your rotator cuff is torn, there are different options for treatment. Not every tear needs surgery, that's very clear. If you have a torn rotator cuff, usually the first line is just rest, avoiding activities that aggravate it, and we often recommend physiotherapy. With therapy, many patients with rotator cuff tears can become highly functional and relatively asymptomatic. If we do consider surgery, it's important to know that not every surgery of the shoulder turns out perfectly. The rotator cuff tendon itself is not a good healing tissue. It lacks cells and blood supply necessary for healing. We have strategies to improve the healing when we do the operation, but you have to know that just because we sew your tendon down to the bone where it ripped off from does not mean that it will necessarily heal, or if it heals, it could still be painful. So once a patient and their surgeon decides that surgery is the right option for them, it's very important to have a discussion regarding risks of surgery and realistic expectations of what the results and recovery are going to be like. In terms of risks of rotator cuff surgery, the actual operative risks are quite low. Anybody who has an anesthetic and you have to be put to sleep for this type of operation could have a reaction to the anesthetic or a complication, but that's exceptionally rare. Furthermore, the actual operative procedure itself is usually minimally invasive. With any cut on your shoulder or your body, with any surgery, there's a small risk of infection. There's a small risk of bleeding and a very small risk of nerve damage. The other thing we discuss with patients is the risk of stiffness that could happen afterwards, and some patients can develop a frozen shoulder. In terms of realistic expectations for results in recovery, you have to know that this is a long-term commitment. People don't have their operation and get back to their activities in 6 weeks. It's often a 6-month to 1-year recovery. People have to know that they may be immobilized for quite a long time in a sling after the surgery, and if you have a large tear, that can be as long as 3 months. Often we can't start physiotherapy until 6 weeks or 3 months after the operation to allow the tendon enough time to heal so that we can safely load through it. First of all, if you're going to have your rotator cuff repaired, depending on the surgeon doing it, it may be done arthroscopically with a camera and small poke holes in your shoulder, or the surgeon may alternatively do what we call a mini open procedure with a very small incision on the front of your shoulder, and that's done under direct visualization. Once we get access to your rotator cuff tendon by either of those methods, then the operation's identical. I mentioned earlier that the tendon is not a good healing tissue. It doesn't have a lot of cells and blood supply. And we're trying to hook it back down to the bone and get it attached and healed there to withstand the tensile forces placed on it with activity. One of our strategies of getting the tendon to heal is actually roughening up the bone attachment site where it originally ripped off from. By doing that, it's a raw bleeding surface. You have cells and blood supply. There are marrow stem cells that can come up through the bone and help that tendon heal and scar down to the attachment site. So we're gonna give you a little bit of a demonstration here showing you a mock-up of some of the type of anchors and devices we use to suture your tendon down to bone during surgery. Okay, so we're here for a brief surgical demonstration. We're going to show you some of the tricks of the trade here and the type of implants and anchors that we use to fix your rotator cuff. As you can see down here, we have it's a model of what a rotator cuff tear would look like. These flaps down here could indicate what a flap of tendon that's ripped off the bone would be, and we essentially want to get them sewn back down tightly to that spot there. So typically what will be done is what we call a double row repair. It's essentially twice as good as a single row. We're fixing the tendon down with 2 separate groups of anchors to get the most possible fixation as we can. So we have interesting devices. This is one called a scorpion suture passer. It's called a scorpion because when you press the trigger, a tail comes out like a scorpion tail, and that captures the suture and pushes it through the tendon. And then there's a little trap door that grabs it and allows us to pull it. So you'll see that come into action, and that's a great thing because it's extremely fast and predictable and reliable for passing sutures far away from your body. One of the anchors we like to use is a knotted anchor here. It's called a Y knot, and it essentially is a bundled, you'll see some bundled thick suture here. And that goes into a pre-drilled hole that we've drilled in the bone. So this would be the area where the tendon is going to be attached. We will have roughened that area up to raw bleeding bone. And we start by punching a hole with a little device like this. It's essentially just punched into the bone to make a pathway for our device. And the very interesting and cool thing about this anchor is that the suture goes in that way and we introduce it, but when we pull on the threads here, this suture here will ball up into a thick ball. And when it goes down a narrow shaft and then balls up underneath, then you can't pull it back. So you're essentially fixing with suture, and you don't need metal anchors or plastic anchors. So we'll demonstrate that here. Here's an anchor going into a hole in the bone. I'm just going to give it a little tap with my hammer here if I can, and see if we can deploy it down. So now we've got it far enough down that it should work when we pull this out. So we're going to detach our threads here. And then we're going to pull our little anchor out here. And when we pull these threads, now the anchor cannot pull out of the bone. So we are going to put a second anchor in here. So now we will pull that little device out. We'll give a tug on our anchors. That little ball will form in there, and that will be essentially our suture anchor points for the repair of this tissue down. So the other cool thing that we use is our sutures here actually fan out, so they're more like tapes. So they're thin here like a normal suture, but then it becomes a thick tape. And that's so that the thick tape will not cut through the tendon, because we tie it down quite tight. By thickening the tape out, it's more pressure on the tendon and it doesn't saw through the tendon. So now we're going to take our Scorpion suture passer here, and we're going to show you how we pass it through tissue. Essentially, we just load it up. We come to the point in the tissue we want our suture to go to, and we press it. It passes it through, and then it captures it. So now we've essentially passed our suture in there, and so we'll repeat that. Okay, so now we've passed our sutures with our device, and essentially those sutures will now put our tendon down. What we're going to do here is we're going to take one suture from each anchor, and we're going to crisscross them so it pushes our tendon down like that. And then we're going to secure it into our second row. We talked about the double row repair. So now we've got a different type of anchor here. This is called a pop lock anchor, and you're going to see why it's called that. So essentially, we're going to load these sutures into the device like this. That's one. And then essentially we're going to tension our sutures down here. We're going to put them in the hole. And then I'm going to pound it into the hole with my hammer here. And then why they're called pop lock, because we have a handle here. We squeeze it, it makes that popping sound. And then when we pull it out, that anchor is now deployed in the bone. The suture is now crisscrossed and it's holding the tendon down. And then we cut this suture right flush with the bone. So if we were to repeat that with the other anchor here quickly, we could pass it through, pass the other one through, and then we will tension it up. And we'll do our little pop. And there we go. So those sutures would then be cut flush with bone, and you wouldn't see them. And then in essence, that rotator cuff tear is now down and being compressed where it belongs. But this is a typical double row repair and some of the devices we use. So once your surgery is done, you'll almost certainly go home the same day. We almost never have to keep patients in hospital afterwards. You'll be given painkillers and instructions to ice your shoulder. You'll likely go home in a sling, and we really want you to keep the shoulder down by the side. We don't want you lifting it or moving it around. You'll be given instructions on how to take care of your wounds and showering instructions. After the surgery, you have to comply to the rehab protocol, and every surgeon will have a slightly different protocol, although they're very similar. And the rehab protocol will vary greatly depending on whether you had a small tear versus a very large tear. We often guide our rehab based on our operative findings. Essentially, we would define a successful surgery as a patient that's largely pain-free, has full functional use of their shoulder, and that's what we're shooting for success. The success rate will vary depending on your tear size. It will depend on your age. In general, for your average rotator cuff repair, I quote patients a success rate of about 75 to 80%. Certainly, again, small tears can be better, larger tears not as good. Just because we sew the tendon down to bone does not mean it will stay there, and some tears will pull off and fail. So at the end of the day, the results are good with this surgery, but it's certainly not perfect. So thanks for watching the video. There's lots of resources on our website at Kelowna Bone and Joint Health for patients in terms of exercises, post-operative protocols, and information about the surgery. As always, if you have questions and concerns, phone the office, make an appointment with your surgeon. They're glad to sit down and answer your questions and alleviate any concerns you may have.